I would like to extend a warm welcome to everyone joining us for today's Bussola Institute webinar on the current and very pressing issue of enhancing health security through multilateral cooperation. Of course, it goes without saying that the devastating effects of the coronavirus COVID-19 have raised the issue of health security to the top of the global agenda. In whatever part of the world you are joining us from today, the economic, social, and health impacts of COVID-19 will have been profound. It is clear that the world was not adequately prepared for a health crisis of this magnitude. There is a growing realization that, going forward, multilateral cooperation in health security is not only highly desirable, but absolutely essential. These sentiments were echoed by many heads of state and government from across the globe when they addressed the 76th session of the United Nations General Assembly in New York just a few weeks ago. World leaders rightly referred to the enormous global scientific collaboration that was required to develop multiple COVID-19 vaccines, and to what was described as the largest vaccine rollout in the history of humankind. But the pandemic also highlighted the tendency, at least initially, to prioritize health security at national level. There is now a greater appreciation of the value of strong regional and inter-regional cooperation in delivering health outcomes, and of the need for ongoing systemic engagement with global structures such as the World Health Organization. Both the EU and Gulf countries have strong track records in regional and inter-regional cooperation across a number of areas. Both are also leaders in humanitarian and development aid, and have also led on strong pandemic responses and vaccine rollouts. Both regions are now also looking at post-pandemic structures. The EU for Health, for example, is the EU's ambitious response to COVID-19. But the programme will go beyond crisis response to address the resilience of healthcare systems. In the Gulf, not only were responses to the pandemic generally swift and decisive, but a number of Gulf states have also been noted for their efforts to support countries in need of major medical aid on a global level. Working together, Europe and the Gulf, drawing on their own regional experiences of the pandemic, they have the potential to provide leadership for global cooperation and innovation in the field of health security. Dr. Richard Burchell, Senior Research Fellow at the Bussola Institute, is currently completing a timely research paper examining how inter-regional cooperation between the EU and the Gulf countries could fulfill this potential for global leadership in the health security field. Before I introduce Richard, I just want to acknowledge that all of our distinguished panelists today come to us with very wide experience and expertise. Each one of them has an extensive and relevant curriculum vitae, so I am only proposing to highlight a few of their many achievements as I introduce each one separately. Our first speaker, as I said, will be Richard. Richard is a Senior Research Fellow at the Bussola Institute. He has advised, researched, and taught internationally on a wide range of issues in global governance and human security matters. He's the author of over 60 contributions to academic journals, book chapters, and think tank publications around the world. He has focused on regional multilateral arrangements in processes of global governance. He has been a visiting professor at universities in Canada, Germany, New Zealand, and the United Kingdom, and has also worked for a good number of years in the United Arab Emirates. So Richard, you are most welcome. And just maybe to begin with, in order to set the scene from your recent research in this area on behalf of Bussola, what would you please take us through what you have learned from the COVID-19 pandemic about the state of the current multilateral system for global health security?
Hey, thanks, John. I must admit from the outset that the research and the analysis of what has been developing is perhaps not as positive as your introductory remarks played things out, but I think we can work to the more positive dimensions because the tools and the abilities are there. What I'll do is I'll just run through some of the sort of quick conceptual ideas involving public health and multilateralism, and then I know my colleagues on the panel are much more experienced and working in the front line of some of this stuff, and I look forward to their views and their sort of thoughts on what's been going on. Now, public health and multilateralism essentially raises a wide range of contradictory positions that need to be addressed and discussed. Public health is very much a national issue. It's a local issue as well, but most healthcare systems are at the national level. Multilateralism is looking for global cooperation. So it's not just the national that's important, it's the globe that's important. And we're hearing that now as we try to come out of the COVID-19 pandemic, that nobody's safe until everybody's safe. And that's an important thing to talk about. At the same time, I mean, multilateralism, interesting enough, in public health has one of the longest histories in international relations. In the mid-1800s, states and others were getting together to discuss what they then called the international sanitary measures, but this involved the spread of communicable diseases. And even over 150 years ago, we saw disagreements over how to respond. We saw states saying, well, you have to go do this, we're not going to do that. And we saw disagreements between politicians and scientists over the best way forward. So our current debates, our current points of contention, unfortunately have a long history. But it's one of those histories that's understandable in many respects. States, first and foremost, have to address their national security and safety. We can't blame them for that. However, the COVID-19 pandemic has certainly shown that not only viruses, but other things don't respect borders. And as the world is more connected, globalization, et cetera, we need to keep that part in mind and sort of try to find a way to ensure that national responses contribute to the global efforts. Now, whenever talking about international organizations, multilateral organizations in response to anything global, the criticisms, the responses, the reactions are the same. States very quickly blame the international organization for not doing enough work. But the way international organizations are set up, they rely upon the member states to do the work. There is no global force of any kind out there. The WHO has regional representation, it has national representation, but it still requires the national politicians, the national health systems to carry things out. So this is a long-standing criticism of international organizations. They don't do enough, but they do rely upon the member states to do it. Now, in this particular area, this immediately runs us into some difficulties. We do have in place, I personally feel, the international health regulations that the ambassador was part of did provide us with a framework and the ability to respond to COVID. Yet it did not come through in the way it had been hoped or envisaged. But it wasn't just COVID. In 2009, during the swine flu epidemic, the WHO very quickly announced it is a global concern. It put in various recommendations and regulations. It was quickly criticized for over responding, and people were reluctant to follow some of the rules and regulations put down. And the 2014 Ebola outbreak in West Africa, again, the WHO was criticized this time for not reacting fast enough, for not putting in restrictions, regulations, guidelines. So essentially, it was no surprise in December 2019 that we heard of a virus spreading in China, but yet we quickly heard criticisms of the WHO not acting fast enough. But the WHO can only rely upon the information given to it by the member states. Under the international health regulations, non-state entities, NGOs, et cetera, are allowed to provide information, but again, it requires the national system to allow that message to get through. Also, what has come very apparent with the setup of the WHO is how it's underfunded and understaffed. We're expecting it to do everything, but yet at the same time, it cannot do everything. So the WHO in May 2020 came up with a review strategy, and that report was recently released this year that brought out a number of interesting ideas going forward. And one of the suggestions was a new treaty to deal with preparedness in pandemics. In November 2020, the EU Council President, Charles Michel, brought out the same idea. Now, in our discussions and looking forward, will a new treaty help ensure we'll be prepared for the next pandemic? Because the next pandemic will be coming. I'm not 100% sure. I think the international health regulations provided us with the tools to do it, the institutions, the processes, but we're back to this key issue of ensuring states do as they're expected to do. Not they're obligated, but expected, I think, is the best political diplomatic way of saying that. But states don't want to report about health outbreaks. It's embarrassing. It takes away from your national mystique, your national good image. And people may not travel to your country, people may not want to visit your country, but we do require the transparency and the openness that the international health regulations envisioned to be seen in practice. So perhaps a new treaty will help focus the minds, but as with most international affairs, as we start to emerge from the pandemic, vaccinations get rolled out, I think quickly the preparedness part will be forgotten about, and states will move back to focusing more on the national and crisis responses over the preparedness part. So while we have lots of good stories out there, I think there are positive stories that need to be articulated, need to be built upon. For global cooperation going forward, we need to get off this issue of reciprocity and sort of diffuse reciprocity. States have to be willing to commit to a global health regime, knowing full well that they won't immediately get credit and praise for it. They won't immediately see the results of it. But in the long term, the global collective will benefit. Now, I know that's very much a normative argument, very hard to turn into a practical political argument, but that's what needs to be done in relationship to going forward. Final point. In talking about multilateralism and global health, I mean, I see a question's already popped up from Wolfgang Pape, talking about moving beyond the nation state and multilateralism to what's called omnilateralism, where we have different non-state actors involved. We're already there with global health in many respects. The top funders of the WHO are a few states, 3 international organizations, and 3 private entities. Getting more actors involved has been beneficial for global health, but equally it causes some problems because funding is focused on specific targets. Everybody's looking to do their own thing, and the global dimensions aren't always brought into account. But yes, we do need to look at all relevant stakeholders in moving forward in global health, and that will contribute to the international scene and improving the multilateral approaches that we currently can try to move forward.
Thanks a lot, Richard. And I'll be back to you again, indeed, with some questions in a while. And I'd like now to go to our second panelist today, former Ambassador Mary Whelan. And throughout the course of a long and distinguished career with Ireland's Department of Foreign Affairs, Mary has been a key member of Ireland's diplomatic team in many countries and indeed in many roles. She has served as Irish ambassador to the Netherlands and to Austria. And from 2001 to 2006, she served as permanent representative to the United Nations and other international organizations based in Geneva, including the World Health Organization. While in this role, Mary chaired the important WHO working group that drafted the international health regulations that indeed Richard referred to a number of times, which now form the legal basis for international cooperation on infectious diseases. You're very, very welcome, Mary, and thank you so much for joining us today. And maybe to begin with, to follow on from what Richard was saying, as the person who chaired the negotiations for the international health regulations, were you surprised at how the world responded to COVID?
Well, thank you very much for that introduction. I was disappointed as to how the world responded. Was I surprised? It's very hard. It's very hard to be surprised. But I do want very much to go back to a point that Richard made. I think that the health regulations and the World Health Organization have, especially in the early days, and especially from some large countries, were under the spotlight when many of the failures were not necessarily the failures of the World Health Organization, but were failures at the national level. And I say that in the context that, yes, I would agree that the WHO should have declared an international health emergency earlier, but you're really only talking about a week or 2 weeks. And do we really think that had the DG declared that health emergency a week or 2 weeks earlier in January of 2020, that would have averted what happened? Because the failures were so frequently failures at the national level. And that is very, very clear. And it wasn't always major failures. It was failures to know what we do know. We know that if you have an infectious disease and if you have a pandemic, you need protective equipment. Where in Europe, for example, were our stockpiles of protective equipment? Where in North America? Where in Africa? Where in Asia? Where our stockpiles? These are not high-tech issues. We know for decades and decades, in fact, you could say for centuries, about quarantine and about controlling traffic. We all have, well, those of us of a certain age have an international health passport. But yet, even in the EU, it took us well over a year before we actually devised a health passport so we could travel between our countries. So many of the failures were failures at the national level. And is that understandable? To some extent, yes. To some extent, no. If I were trying to improve the system, and we all must learn our lessons, I would first of all say, again, we must look at the global level, at the regional level, and at the national level and say, where have we gone wrong? Now, the WHO has done that with a hard-hitting report. Mm-hmm. That sort of exercise was envisaged under the international health regulations. And they have produced that, they've discussed it, and they're moving on from it. I'd like to see that replicated in regions. I'd like to see it replicated at the national level so we can do better the next time.
Thanks a million, Mary. And just maybe to follow on from that, and in the same vein, the international health regulations demonstrate a global commitment to a common cause where both diplomacy and technical expertise come together. In your view, just maybe following on from your earlier comments, has this commitment to diplomacy and effective action for global public health been weakened or strengthened by the COVID pandemic?
I'm inclined to think it has been strengthened.
Great.
I think we've all got the lesson. Something happens in China, it affects people in Ireland or in the UAE or in South America. I think that message has come through clearly, and it does require strengthened cooperation. So yes, I would be positive about that, yes.
Great. Lovely. Well, I'll come back to you again in a while, Mary, and we'll be when we're doing the round of questions. Thank you so much. Our next panelist is Dr. Emmanuel Azimov, and Dr. Emmanuel is an associate professor of health administration and policy at the Mohammed bin Rashid School of Government in Dubai, in the United Arab Emirates. He's the author of over 135 publications and has co-authored several books and book chapters. His career experience includes policy analysis, quality assurance and management, nutrition and dietetics, health and safety, teaching and institutional research. Dr. Emmanuel, you're most welcome. It's great to have you with us today. And maybe just to begin with, I'll zone in on a part of the world where you're working at the moment, the Gulf states. I would say the Gulf states are in a difficult position from looking at it from my perspective, having worked indeed in that part of the world for a number of years. They're in a difficult position when responding to global health crises, as they are major travel hubs to begin with and home to so many different nationalities. Say, putting this challenging, in the context of this challenging situation, how effective do you think the Gulf responses were in dealing with the pandemic?
Thank you. Thank you for this question. Firstly, I'd just like to thank everyone for inviting us as a School of Government to be part and parcel of this discussion on health security. In response to the question, in terms of how effective the Gulf response has been, ever since the outbreak took place in the early quarter of 2002, in the year 2020, we've seen that countries like the Kingdom of Bahrain, the United Arab Emirates, as well as even Saudi, were one of the first sets of countries within this region to recognize that this is an issue, as by and large we're transforming educational mechanisms from your face-to-face mechanisms to your e-learning aspects. These laws and policies were starting to put into place. Now, in general terms, I would say, yes, it has been quite an immense of positive responses coming from this region when dealing with the pandemic in itself. A couple of reasons, apart from closing schools and moving the mechanisms and so forth, also making sure and having a series of protective measures in order to prevent the spread of the COVID pandemic. As we know, according to the WHO, we know that every 100,000 cases, it takes 67 days. The second 100,000 took 11 days. The third took 4 days. And the fourth 100,000 took 2 days. And then every 24 hours, you have 100,000 new cases. So as a result, countries in the Gulf in itself recognize that this spread is moving at a very rapid rate. So travel bans were implemented, enforcing policies for wearing masks, as well as ensuring that also to have citizens and residents within the countries to be within the country as opposed to traveling abroad and so forth. Also having lockdown, curfews, policies into place, movement restrictions across the same countries in itself, making sure you have social distancing procedures, as well as having your quarantine tracking, your contact tracing, your health screening. All of these policies were, by and large, at the beginning of at the cusp of when the pandemic was announced on March 11th, following into April and so forth. Earlier in that year, the School of Government produced a report on a rapid response in terms of how the UAE has been managing in the first quarter all the way till April of last year. And it really highlighted some of the positive lights with respect to managing in the pandemic and so forth. In addition, even knowing that this region is very strong on the religious activities and so forth, this was a strong message to the Muslim community, to the Christian community as well, even though it's a small community where places of worship moved from being face-to-face or physical gathering to online and online gathering and so forth. So all of these were strong messages from the government, from the religious organizations in itself to ensure that the spread of the coronavirus was mitigated and so forth. In addition to other mechanisms in terms of the ease of detection of the possible cases. For instance, the UAE had launched its first mobile drive testing center where individuals could get tested while remaining in their cars so as to minimize that contact with other possible cases. In Oman, for instance, you also had volunteers that were asked to be part and parcel of making sure public health campaigns go across and so forth. So these are some of those positive lights with respect to managing the pandemic as a whole.
Thank you very much, Dr. Emmanuel. There's one other issue that just maybe you might like to respond to at this stage, and this is looking at the Gulf states, looking at the across the world, but in your opinion, is the response to the pandemic likely to have longer term impacts in the Gulf region? For example, in relation to the empowerment of women and in relation to youth involvement? Mm-hmm. Just from things I've read in some of the local media.
This is quite an interesting question. Hence, one of the reasons being the UAE as an example, women led a lot of the initiatives and programs during the pandemic in itself. For instance, the official spokeswoman, the official spokesperson for the UAE was indeed a female, as well as many of the other roles in terms of bringing public health awareness, in terms of the vaccination drives, as well as the trials and so forth that were taking place, the vaccine trials and so forth. Women were leading in these roles. Of course, men were involved, but many of these initiatives have it really empowered women, not for the first time. However, this is a continuing action that has been taking place. You might be aware of at least 1/3 of the UAE government, as an example, are comprising of women. So they are actually part of the fabric, and it really allows for women to be empowered within the context, as well as in Saudi. In the press releases and so forth, there were also involvement of women in terms of relaying government initiatives and laws and regulations and policies and so forth. In terms of the youth's involvement in itself, and this is quite an important element, in that we know even though the young people themselves tend to face lower risks of this pandemic as a whole, somehow we saw the additional advantage of the young people to play an active role in mitigating the crisis and really helping to prepare for the recovery through the youth organizations in itself across countries. For instance, the youth councils, at the federal levels, there are youth organizations as well, running campaigns, creating awareness, making sure that there's some sort of support for the elderly and the vulnerable populations and persons of determinations and so forth. Young persons were also empowered to offer online trainings as well, share data, engage with policymakers, researchers, entrepreneurs, and so forth. So these were some of those positive impacts, if I may say, coming to empower women as well as the youths as a whole.
That's great. Thank you very much, Dr. Emmanuel. Now I welcome our fourth panelist today, Professor Anthony Staines. And Dr. Anthony Staines is Professor of Health Systems at the Centre for Integrated Care and School of Nursing, Physiotherapy and Community Health at Dublin City University. He is a distinguished epidemiologist and public health consultant whose research focuses on the use of information in health systems. He has a particular interest in child health and disability. working closely with the Health Intelligence Unit in the Health Services Executive in Ireland, Professor Staines has led several projects to deliver innovative health information approaches in Ireland and in Europe. So, Professor Staines, just to come back to some of the issues that have been touched on already by all of our speakers, and maybe in particular the discussion that the comments made by Richard and indeed by Mary in relation to the World Health Organization. In your view, during the COVID pandemic, has the information provided by the World Health Organization and other bodies at global level helped to inform and support public health policy and decision making at a domestic level?
It is worth looking into the history of this. You mentioned the international health regulations, which actually date from 1851 with the first international sanitary convention.
Unfortunately, I think your microphone, there's a funny, there's a strange noise coming as well. So maybe you try again. Sorry.
Just can you hear me now? We're moving gently forward. So.
Maybe try again. No.
It's worth going. Let's see if I can turn my microphone. My apologies. This was working.
Yeah, it's working now, I think. No, it's still not. Any success?
Technology, especially when it works.
It worked perfectly before this, when we chatted earlier on. So
I don't know if it's forward, so
or maybe move back a little. I don't know. It's
is that better?
It may be a bit better to be back a little. Try it anyway. We'll try.
So this goes back a long. These discussions and arguments go back a very long way. The first international cooperation in health was driven by fears of cholera. And the International Sanitary Regulations start in 1851 with a row about quarantine. Some countries felt quarantine was allowed, others felt it was not, and they didn't agree and produced a set of draft regulations which allowed for both options. And these disputes, these debates between countries have continued ever since. And it is part of a process that says, we can control this. We can manage this. And if COVID has demonstrated anything to us, it is that we can't. We've now had 3 novel human coronaviruses in the last 20 years. We've had SARS-1, which stopped for reasons we still don't understand. It had a 10% death rate, but it stopped. We've had MERS, which has a 30% death rate, but spreads poorly from humans to humans. It spreads from camels to humans, and it's still endemic across the Arabian Peninsula as I speak to you today. And we now have SARS-2, which is a highly infectious respiratory virus, but not as lethal, not as fatal as either MERS or SARS-1. We have a number of other zoonoses around the place. Nivovirus, which is bat hemorrhagic fever. Currently, a large part of Indonesia is on lockdown because there's been an outbreak of nivovirus there. So these are not new features. And we understand where they come from. We understand how the way we work in our ecosystems leads to ecosystem damage, which leads directly to the spread of these viruses into our population. The Chinese government slaughtered more than 3/4 of the pigs in China 2 years ago because of African swine fever. But no one said, why does African swine fever spread so fast in pigs? And it spreads fast in pigs because we use a particular model of peak production, a model which cannot be made safe. And information is essential to understand what's going on. But putting that information together, seeing how information flows between different policy domains, is really going to be critical. We have a situation where what happens in health is heavily influenced by agricultural policy, transport policy, energy policy, education policy, none of which have responsibility as such of health and healthcare, but all of which have dominant effects on population health. It's estimated that healthcare contributes about 1/5 to the variation in health within populations. We have a virus which behaved in a way that should have been well understood. It was a respiratory virus, it was fairly infectious, but we have many examples of such, influenza being the one with which you are most familiar. We actually had pandemic plans designed specifically for pandemic influenza, but we didn't make them happen. And some countries, the United Arab Emirates amongst them, responded very effectively to this virus. And other countries, the whole of the European Union amongst them, did not. And it's easy for us to look at Britain, Brazil, the United States, where the response has been quite extraordinarily bad. But actually our response was not very good. And what Europe did with this virus was we spread it. It came from China to Europe, largely, and largely it went from Europe to the rest of the world. It was on us. There was no law of nature that said this virus would spread. We made political decisions, political choices around transport, around response to this virus, which led to global spread. The virus did not get to South America from China. It got to South America from North America and from Spain. And we know this because we sequence the virus. We know how it spreads. And we share that information. And that's been incredibly powerful, but it's also been incredibly frustrating because we know what's going on, but we failed to do anything effective about it. So the information is there. The information is not perfect. The information is slow. The information is incomplete. But the information, adequate information for action is there. Because public health is not an engineering discipline. We do not require perfect information to build a structure that will stand for the ages. We require enough information to make a decision as to what to do over the next couple of weeks.
Yeah, yeah.
We had that information.
Great.
We didn't act on it.
Right, right. Thank you very much indeed. The microphone is still not great, so I leave you for a minute. It may settle down, and maybe I'll go back just to Richard for a minute, or just for a few seconds to talk about, say, regional multilateral institutions such as the European Union. Does your research show that they have a more extensive role to play in responding to major health security concerns and in promoting more multilateral cooperation?
Well, I would say my initial response would be yes, just because in the work I've been doing in terms of global governance,
Sure.
I find that regional arrangements are more effective than global arrangements. And there's a tendency in global governance for mini-lateralism, smaller groups, et cetera, But as Professor Staines just pointed out, the European Union approach in many respects actually contributed to the spread of the virus, because the European Union tried to stick to its principles of free movement, of no national borders. Nation states then said, no, we do have national borders. And what resulted, unfortunately, early on was, again, the regional governance arrangements and the national governance arrangements almost being at odds with one another, competing for different priorities. I think the diplomacy has come through, and we're getting there. But I think, again, looking forward in terms of preparedness, it's going to be an interesting issue, because in terms of, as the ambassador spoke of, basic things like PPE and other sort of easily accessible or easily manufacturable necessary equipment, we have to import primarily from China and other places. Now Europe is saying, okay, we need to make sure we produce it within Europe. But then nation states within Europe are saying, no, we need to produce it within our nation state, which suggests they may not be sharing with the European Union or even the global scene going forward. So the tensions that I spoke of at the opening between the national and the global are in many respects just exacerbated at the regional level as well, because it adds another layer. But it's a necessary layer, as Europe has shown. And in many respects, if we could start spending some more time looking at the Gulf, we could find out if the GCC had been more active during this, would it have been more effective? It's an open question, who knows, but it does something that needs to be addressed going forward, because the regional approach does allow us to get that information together on a wider scale than just individual nation states, and allows for more sort of measured response based on the regional context, instead of just going for the more sort of local national approach. So it may be helpful, but at the same time, we still face these sort of difficulties between national priorities and wider priorities, be them regional or global, that we do need to work through as well.
Great. Thanks so much, Richard. Mary, just to follow on to in the discussion that we were having in relation to the international health regulations, as you are somebody who really knows this scene very well. The revision that was designed, chaired by you, that was designed to give the world an effective system for responding to global health issues. Do we now need, do you think, to further revise these regulations to take account of the experience of COVID? Or do we need a completely new treaty on pandemics specifically?
Well, it's actually neither of those things.
Right.
I think that the International Health Regulations 2006, to give them their official title, I think that it would be very difficult to negotiate something as extensive as that today. Yeah. And it is very interesting when you look at the language that is being used around the proposed framework agreement on pandemics, that it is not attempting to reopen that question. And it refers to a new treaty or a framework agreement as being underpinned by the IHR. And there's good reasons for that, because some of the criticisms that are made are simply not valid. The International Health Regulations 2006, in fact, does not depend on governments for information. Governments are required to report, but the WHO can actually take information from non-governmental sources. And that is a specific provision of the IHR. Some of that you would have great difficulty in getting agreed today. But what has been decided at the World Health Assembly on the 31st of May was that this December, there shall be a meeting which will discuss the possibility of having a framework that would be, if you like, complementing, but it would be alongside the IHR. Whether that will go anywhere quickly is something I would have concerns about. I would like to think it would, but to be effective, a framework convention will have to be signed up to by an awful lot of countries, almost universal, as are the IHR. And getting that degree of consensus is quite difficult. If I were to look at areas within that I personally would like to see more work done, it's on some of the areas there which Anthony referred to. And that is the area of bringing together a little bit more the knowledge of animal, plant and human health, bringing those issues closer together. I should also like to see or know whether we can and who would be responsible for greater controls over what is going on in research laboratories, because that seems to be a slight black hole out there. So there's some of the things I think it would be good to have something complementing it, although it would be called a framework agreement, but it will it will inevitably take time, I think. I want to come back to something because I think it's important. You can't criticize an institution or entity for doing what it was never had the responsibility to do. And I'm saying this in relation to the European Union. The European Union has not got responsibility for health issues. What we have found, and that's not by accident either, it has tremendous responsibility for animal health issues, but not human health issues. Human health systems are the prerogatives of the member states.
Sure.
And what this has pointed out is, and I totally agree with Richard, and what it has pointed out is the need for greater collaboration, greater cooperation, and maybe a little more than that at the regional level, including at the European level.
Great. Thank you very much indeed, Mary. Dr. Emmanuel, just to come to you, and you can keep this answer reasonably brief, just keeping an eye on time here. Transparency at the national level in relation to the impact of the virus is essential for coordinating global responses. In your view, have the Gulf states been active in ensuring transparency?
Without a doubt, I would say yes, of course.
Right.
They've been quite active in ensuring transparency. For instance, the statistics in the report shows that, at least 65% of all the testing within the MENA region are actually attributed from the Gulf states. One of the important factors that played a role here is in terms of governance and clear communications across the board, where at that preparedness side, and Richard covered this earlier, and also Professor Anthony, well, all the panelists as well, the importance of organizing a disaster, making sure you have your documentations and to have your essential persons on standby to be informed and have the ability to assess these resources and so forth. Now, in the cases of the Gulf countries, the governance structure is quite clear on this front. Also, keeping in line the public-private partnerships as well. So, yes, transparency is from the government point of view, but also with the working relations on the private sector as well.
Thank you.
That's in summary.
That's great. Thanks a lot. And Professor Anthony, to come back to you again on this same issue, in your view, have the European states been sufficiently active in ensuring transparency in relation to patient numbers and the actual impact of the pandemic? I'm afraid we're gone. Mike has gone completely. Do you want to try again? No, unfortunately, I can't hear. I don't think anybody else can. No, unfortunately, I'm really, really sorry about that. We're sorry to lose your view on it, your views. If maybe there's no way of turning it on or off the mic, and so hoping it would work again. And I'll come back to you in a few moments again. Richard, just maybe while Anthony is having a further look at the microphone here, I'm just, from your research to date, we know that COVID-19 is having a significant global economic impact apart from the health impact, and that climate change continues to also be a major security issue across countries. How can we learn, do you think, from the shortcomings in the COVID response to ensure an effective reaction to all of these various types of phenomena in the future?
Well, that's it's an interesting point where we can either put a positive dimension on it or a slightly more skeptical dimension. I'll start off with the skepticism, because I must admit, and sort of looking at this response further, I feel it doesn't bode well for climate change. It's interesting to note that in looking at the responses to the pandemic, there was some slowness at the national level to admit there was an issue or there was a problem. There's still a few states out there that say COVID has never ever arrived. So we know where that is. We know why that is happening. And then there was the quickness of many states to say it's over. Then we hit the second wave. Okay, it's over again. Then we hit the third wave. It's over again. And we're slowly getting around to the idea that this is endemic. It's becoming endemic. And it's going to be sort of useful to see how the preparedness then moves forward. And I think that's an important point that has been raised by everybody, is that we need to look better at preparedness over the long term, not the immediate term. However, in global politics, preparedness is not that sort of glamorous. To say you were fully prepared for something, you can't be on the news every night saying, hey, we've done this, we've done that, our figures say that. Crisis response is grand. You can be up there every day saying, we responded to the crisis, we've sorted it out. And we're seeing this with climate change. I mean, the impact on global security on individual health is by some measures larger than COVID, but yet we don't see the urgency. We have the big meeting coming up later this year. So hopefully the sort of commitment, diplomatic commitment that Ambassador Whelan spoke about earlier, we'll see carry over into the climate change element. But I think this is a good lesson for us to see how we view, or how governments and states and international organizations view threats to human security at the global level, because everybody knew, or everybody was saying, excuse me, that another pandemic was coming. And as Professor Staines pointed out, it was well known, it is happening. But will we focus on the, I don't want to say boring, but the less glamorous aspect of being prepared for it through global cooperation, not just national preparedness, as opposed to just responding to it.
Great, thank you very much indeed. Mary, if I can come to you again, you have recently written that in its widest sense, I think, Anthony, your mic is making a lot of noise. Thank you. You've recently written that in its widest sense, foreign policy is the expression of a state's domestic policies as they impact on or are impacted by the external environment. Just as some states now appear to be seeking to make themselves more self-sufficient, maybe a form of isolation in some ways, has COVID led to an abandonment of multilateralism as a means of addressing global health issues?
No, I would absolutely say not. I would say the absolute opposite.
Right.
That's as it should be. We do need, and nobody is saying, nobody since the last American election is saying we need to get rid of the World Health Organization.
Absolutely.
So absolutely not. But I would just like to pick up one point that I think Anthony made earlier and Dr. Emmanuel made in his initial statement, and that is the whole area of communication. There is the importance of communication at the global level, getting the information out, getting the science out there as well. But also what we have learned from this environment is the importance of communication to different age groups, different social groups. And I think Dr. Emmanuel spoke about that, about the youth, about bringing women in and looking at minorities. And one area where I think we have been very, if you like, complacent, has been dealing with what has been a growing problem across Europe for some time, this vaccine hesitancy. Now, we do know some European countries, the rates for vaccination for childhood MMR vaccine are not great. And this is an issue we need to confront, the fake science. And maybe this is an area also, not so much you need rules at the global level, but you need to initiate a discussion and find out how do we deal with this problem of fake science.
Great. And there's another issue probably side by side with the vaccine hesitancy, and that's the whole issue of vaccine equity. We also need to have a major discussion on it because there are so many conflicting views. Well, two, I suppose. Thanks a lot, Mary. Emmanuel, again, keep this very short because we're coming, believe it or not, close to the end of our time. I'm so sorry we can't hear. Anthony, do you want to try it again?
I don't know if you can hear me now.
It sounds as if it's coming from the bottom of a hole somewhere in the ground.
I am sorry. I do beg your pardon.
Yes. Listen, we'll have you again on something because we really missed your wise counsel, so I'm really so sorry about that. Do you think, Emmanuel, and again, if you can do this in a couple of sentences, going forward, have the Gulf states learned from the COVID pandemic how to build sustainable systems for a more effective response to the next pandemic?
The answer is it's a bit in between, yes. One of the important thing, and we know this from having those systematic approaches and leadership thinking for managing pandemics. That last phase of recovery and resuming back to life, as we would say, one of the things that countries tend not to do is document well those lessons that has been learned. So it's really fundamental, and I know some of the Gulf states have been doing it, as well as within the Middle East region in itself. It's documentation of this so that ensure that we have those sustainable systems for future, as well as making sure we iron out those issues of managing those fundamentals of communication after the crisis and the emergencies and so forth. So this is really critical in summary.
Great. Thank you very much indeed. Unfortunately, we're coming towards the end of the discussion at this point, but I'd like to put one final question to each one of you. The reason that Bussola exists is to act as a bridge between the Gulf and Europe. So in that context, arising from our discussion today, and indeed from your own experience, why is it now more important than ever for Europe and the Gulf to cooperate more closely on health security? This is just to your thoughts in literally a sentence or two because of the time factor. So we'll start with you, Richard.
Okay, I mean, the need for cooperation between the two regions, I think, is essential from the impact we saw of the virus in shutting down transportation and trade. I mean, they're closely linked in that way, but they're both crossroads for global activities. As the various panels have pointed out, things move from one to the other. So the necessity of cooperation there is important, but also it's an area in terms of global health where I think the Gulf and Europe could become the leaders in ensuring effective funding for the WHO, because the WHO is facing a funding crisis on many levels. And this would be a space where the two regions could bring that political will together to ensure the organization is better prepared going forward.
Great, thank you. Mary?
No, very much along Richard's lines. I think that the effectiveness of any response goes on the degree to which you bring people along. So if you have two regional organizations like the EU, like the Gulf Cooperation Council working together, that helps to strengthen the global consensus. And that has to be a good thing.
Brilliant. Emmanuel?
To build on the point of funding, one of the priority for this, in order for this to work, is really to work on what established and existing partnerships are there between both regions. Why not share resources instead of reinventing the wheel? And we could learn from each other as well. So also making sure we build those capacities among the stakeholders on both ends in order to enhance health security as a whole.
Thank you very much. We'll try, Anthony. Probably won't work, but let's try.
We'll try. Viruses don't respect borders. Our response to them must not respect borders either. We must be able to reach out across borders to deliver effective responses.
Great. And your microphone has improved considerably. I'm sorry about that we couldn't hear more from you. At this stage, I want to express my enormous thanks to each one of our distinguished panelists for bringing their considerable experience and expertise to this important webinar today, and for sharing your insights into an issue that affects not only every society, but all of us personally. And whether from the perspective of public health policy, health systems innovation, health diplomacy, or global governance and human security, there is a growing consensus that the global community must respond to the necessity in the health field. Indeed, the Independent Panel for Pandemic Preparedness and Response, established by the WHO to provide an evidence-based path for the future, has strongly recommended: 1, more effective national and international cooperation; 2, the establishment of a new global surveillance team; and 3, the immediate investment in greater preparedness. With some of the world's largest economies increasingly focused on their own concerns, there is enormous potential for, as you've all been saying, Europe and the Gulf to provide much needed global leadership on this critical issue. Indeed, the Belgian Prime Minister, Alexander De Croo, highlighted the importance of this collective approach very succinctly when he addressed the recent session of the UN General Assembly. And he said, no one is safe, and I know somebody has already said this earlier on, no one is safe until everyone is safe. That has become our guiding principle in fighting the pandemic. Let that guideline inspire our actions every day. Finally, I want to thank very, very sincerely our many guests who joined us today for the webinar. And I'm also hugely grateful to all of my colleagues at Bussola for their great support and commitment. Thank you all very, very much. Thanks a lot. Bye-bye.